Welcome to the Behavioral Health Eco Series. This is a training brought to you by the Center for Substance Use Training and Telementoring CSTAT, a division of the Be Well Institute here at UT Health San Antonio. My name is Andrea, and I will be helping to facilitate this class. Before we start, I want to remind you that this session is being recorded for later distribution. The information that you see listed on the chat will not appear on the recording, so we invite you to add your names, email addresses, and affiliations on the chat so you can help us with attendance. If you need captionings for this class, please navigate to the bottom part of your Zoom windows and click on the captioning feature. And for those of you who are new to this series, this is a 1-hour session. We're going to start with a 25-minute didactic presentation, followed by your questions, and then someone from our community of learners will discuss a case with us. This is the opportunity that we all have to share our thoughts and ideas about the case, share our experiences. So we definitely want to hear your voice in this part of the session. We only ask you, if you're going to participate, to please raise your hands first and wait until we call your name before muting your microphone, just to ensure that we have fluid, lively conversation and all of us have the same opportunity to participate. And with that, we're going to start with introductions from our behavioral health hub of experts. Katie Dundonville, nice to see you. How are you today?
I'm doing good. So my name is Katie Dondenball. I'm a clinical psychologist at UT Health San Antonio. I lead our Strong Star training initiative, which is focusing on training mental health providers in evidence-based treatments for PTSD and suicide. So I'm really happy to be here today.
Thank you, Katie. Didi.
Good morning, Dee Stout. What do I do? I'm a behavioral health counselor focused on substance use disorder, motivational interviewing, trainings, stages of change, harm reduction, trauma-informed work, associate professor at St. Mary's College in Moraga, California, getting ready to join UCSD, San Diego, in their AOD certification program, and busy. Thanks for being here, everybody. I know we're all busy.
Thank you, Didi. And Melissa Simpson, our case presenter of the day. Could you introduce yourself to the group, please?
Sure. Hi. Thanks for having me. My name is Melissa. I'm an LPC associate at Rise Inspire Academy, and I'll be presenting a case later on. Thank you.
Thank you, Melissa. Jasmine.
Hello, everyone. My name is Jasmine Vidal, and I'm the ECHO Program Coordinator. Thank you for joining us today.
Thank you. And Dr. Antoine, whenever you're ready, we can start sharing your slides and you can take it away. Thank you.
No problem. Thanks, everyone, for being here today. Always good to see all the attendance, and hopefully it's going to be a helpful conversation. Coming again from Baltimore, Maryland today, and where I'm at the Johns Hopkins University School of Medicine, director of two of the substance use disorder treatment programs there. And I wanted to be able to talk today about how we could advance recovery through telehealth. Thinking about technologies and the behavioral health services, and that's been a lot of what we've been doing here. So my goal is to focus on objectives beyond the disclosures that are typical there, thinking about how we can explore the potential role of telehealth in behavioral health treatment, and also thinking about the barriers to implementation, because that is something that I've had some experience with over the past few years. And I'll talk about why we came through those barriers and why we ended up going in that direction in a lot of the work that we do here. And then talk about the emerging trends and the future possibilities of integrating that telehealth into different services that we do. So those are the goals that I have, and I'll be very curious to see what questions come up, because there are different aspects of this for everyone involved. So I'm going to bring some of the slides back also from my previous talks and thinking this through. And really the goal is ultimately the same, engaging the individual with where they are. And it's going to be a shaky process. And that's why I use this, which is a psychological term, the shaky bridge phenomenon. And, a person is going through their process of change, growth, sometimes achieving abstinence or other behaviors, as we think we'll see in the case presentation later on in the session. But the goal is to figure out how to get that person across this shaky bridge process in a way that engages them and keeps them moving forward, not backwards and not falling off the process, of course, but it is how to engage that individual. Within that, it can be a multi-level approach. Sometimes that can be at that individual level, but it can also be at the clinical program level where you need to think about a structure that looks at the whole thing. And then also there's an organizational, administrative, and cultural aspect that goes into the treatment planning process. As we talked about many times in other sessions, social determinants of health often ends up being a common component of that. In the past, we've talked about community or neighborhood built or the stability of the person going on, or maybe even their educational access and quality. When it comes to telehealth, however, that's where you really start to think about the healthcare access and quality, because telehealth has been shown to be a way to increase those in some ways. And I'll talk about the pluses and the minuses of that. It's not all roses when it comes to telehealth, but it has been shown to be a way to address some of the social determinants of health by making sure there's a way to access that care. Now, I'll harken back to a place where I work on a regular basis. I'm actually sitting there right now in a telehealth room we built up during the pandemic. But in 2012, I've been part of a clinic called the Cornerstone Clinic at Helping Up Mission, where we house and put a clinic, an operational clinic in this building, and now another building where I'm sitting, to provide substance use disorder treatment and mental health treatment in that space. We brought clinicians that were on a campus about 5 miles away and brought them into this building, got it accredited separately, and said, we're really close by now. We're 50 feet away from where the individuals need that care, because otherwise they would be unhoused. And we said we would treat people that are in this building. And it's a good setup overall. At the beginning, we were able to prove and find a way to increase our engagement such that even now we have between 80 to 90% engagement at the IOP level of care, which for us means that they attend at least 9 hours of treatment per week when they're coming in, and they stay for almost 2 months. And we extend that treatment by a long period of time. That's a longer period of time than the unhoused individuals there that are not engaged in our treatment. A great setup, as I mentioned, when you're on site, when you're a few feet away and you're able to engage with that. What's happened more recently in 2022 is that we've expanded that to now treat women and their children. So there are actually now 200 women in the building and 50 of their children. That's the capacity. We have almost gotten to full capacity there. So it's been an interesting situation to have to do all the different types of transportation, part of which is through the Johns Hopkins Center for Addiction and Pregnancy, where we started that partnership. And that's allowed us to have those individuals receive methadone and buprenorphine for their opioid use disorders or get other types of psychiatric and medical treatment that they need on the campus. A lot of transportation involved there, but an expansion of the types of care that we're able to provide. How are we able to do that? Did we pack more people in the building? Not always, because what happened is in the middle of the pandemic, COVID occurred, as we all know. And what that meant is we couldn't have all those people in the building as we did before. With 200 people in one building and 400 people in another building, you had COVID outbreaks very often. And that made it difficult to continue what we could do. So we had to shift. And we were able to get a grant from the Johns Hopkins Urban Health Institute. And that allowed us to get telehealth equipment into the building. That comprised of AV equipment on the walls where you could have conference calls and video cameras that were very clear. And we also even had to bring in internet from Johns Hopkins into the building, so it was at a faster speed. Because without that, there was a lag in order to even conduct any of these telehealth sessions. We even bought iPads and tablets for individuals to go to their isolation chambers when they did have to go into isolation for COVID. And it really allowed us a lot of flexibility for the counseling staff to do their services from home while we maintained everything with the continuity of care. So it was pretty timely. I think without this grant, we would have had to have closed because the outbreaks that were happening for COVID at the height especially were making it difficult for us to do what we normally would do. We would have groups of 10 people in the past pre-pandemic, and that wasn't going to occur during COVID. So this is why we made the change. And people were thinking at the time, well, when COVID, goes away and the public health emergency ends, we would just go back to normal. We'd go back to what we had before. And it turns out it's a little bit different. Certain things were held on to, and certain things we did revert back to normal in terms of in-person groups. Again, I'm on site right now in the clinic, but I still do some of my telehealth sessions in spaces where the person might be a few miles away. And it's allowed for a lot of different experiences. Overall, one thing is undeniable, that we did a lot of visits. And this is a tabulation of the top practitioners in the Johns Hopkins space from 2020 to 2022. And you can see there's a large gap between the clinic that we were at the Cornerstone Clinic and the other providers in the system, showing that we were able to engage people at a high rate. And I think that's a good place to start, but it's not the end all and be all. It's just to show that it's a feasible way of doing things and continuing access to persons. And COVID forced our hand to do it, but it's not where we've continued. One thing that's come in particular out of the combination of services for the CAP space is that we've been able to close some disparities in perinatal substance use disorder treatment and also perinatal mental health care. Prior to the pandemic, we were actually at 5 patients. We were at a small space there in the Bayview campus. That's the campus where I typically work, but we weren't able to maintain patients that long, and we were down to a census of 5 patients. By making that partnership, like I mentioned, and housing the clinic and allowing them to stay at Helping Up Mission, and then providing transport back and forth with hybrid, meaning in-person and telehealth appointments, so there would be more flexibility. We've been able to almost quadruple, we're almost up to 30 patients now, and that we house for a longer period of time, up to 1 year postpartum. And we've had several, over 100 calls over the past year, which is far outpacing where we were before. And 42 intakes was just from that year-long stretch that we've talked about there, but it's really outpaced what we were doing before. Again, showing that there's increased accessibility and acceptability to what's going on. I think without the telehealth option, you would really make it difficult for a person to go to their OB appointment, their psychiatric appointment, and get their dosing in the same day. And I'm hoping that we can tease this out in terms of making sure that the health disparities for perinatal treatment don't just stop at the volume of visits, but also smooth out in terms of who is able to access this, whether it's gender, race, ethnicity, and other options. We need to look at how health disparities can be addressed this way, because when the system provides the digital devices and the internet, that makes it easier. If you put all the burden on the individual, there might be a difficulty there. So I would say this is a proof of concept of how we can get past the digital divide if we put up that first infrastructure to create that access. Now, part of this is a downside. And like I said, this is not all roses here in terms of what we're trying to do. Telehealth is not going to solve everything. And this is an article from earlier this year that looked at telehealth expansion for Medicare beneficiaries, and not just the number and the amount of access that's happening, but the quality. Because what has been shown is that Medicare beneficiaries at the height of the pandemic, there was a 32-fold increase in utilization of telehealth, showing that this is what everyone's going to do. Now, post-public health emergency, it really has shown that the access to those telehealth services is still high above where it was before the pandemic, but it's gone down significantly. So there's that enthusiasm and that necessity that happened during the pandemic, but it's still going to be used moving forward. What this study showed that was published in one of the JAMA networks, the journal, the JAMA journal, what it showed was that even though there were still high uses, and I often don't read the slides here, it does show that there is a suggestion here that there's a high capacity for telehealth services, but there needs to be more information to look at what the quality of that care may be, because it might lead to higher hospitalizations, as was shown in this study, or it might lead to higher total healthcare costs as well. So while there were many uses of telehealth, it's not quite clear whether the quality is always going to be there. And this study looked at different disciplines, sometimes psychiatry, behavioral health. It also looked at medical somatic care, as we would think about. But one thing is undeniable, that it is reflecting an ability for this type of system to increase the capacity for providing services. And they'll look deeper and see what's going on from there. Outside of that, I think we also need to think about what else it can do on the positive side. Another article that came out later in the year, so maybe a couple months ago, is that the patients expressed an experience there as well. Sometimes you can look at the financial or look at the provider experience, but it's very important to look at the patient experience in this whole thing. And this article that came out earlier this year said that it does increase that access to care because there's a provider shortage. One of the reasons I do telehealth is because I do have to be in 3 places at one time sometimes. And sometimes schedules don't make that easy to drive across town. That was tough pre-pandemic. But now I can, have a session here physically in this building, do a session with a person who might be housed about 5 miles away, and maybe gives consultation to a place in Texas, like I'm doing right now. And that is what is possible with telehealth. You can give more with less time and take away some of that travel, which could address this provider shortage. Behavioral health providers, especially psychiatrists, are becoming harder to find. But this article also pointed out that there are multiple barriers that still exist. We were fortunate to find a grant to give us the money to buy the AV equipment, the audiovisual equipment, to put up the things in the rooms and conference rooms, and to buy the internet in order to get the bandwidth to do this, literal bandwidth to do this. But the digital divide is big. And the digital divide means that there are certain populations that do not have the access to the devices. And even if they have the devices, they may not have the data plans or the right software to access all the sessions they could for telehealth. And that's known to be in certain populations, especially populations of color. And even if you have those devices and that access, there's a large amount of literacy that goes along with that. I use the term digital fitness during the pandemic to know, like, does your client know how to use Zoom, or know how to log onto the computer, or even do the things that are needed to log into a telehealth session? It often can be multiple steps. And I even had an issue with a client this morning where they didn't know how to log on to the WebEx portal. I actually don't use it that often. So we shift to a way that makes it easier for them. Another barrier is one that's clinical in nature, in that, how does the person want to engage with their provider? Not everyone wants telehealth, and that's understandable in many ways. Human engagement is very important to that whole thing. And in the world where we've done more things online, social media, Zoom, some people still want that human engagement and find that very valuable. On the other hand, there are certain populations that have been shown to do well in more of a digital interaction. Persons with very high anxiety, sometimes military, and there have been studies have been shown that there is less likelihood that they would want that one-on-one close interaction, because it might pique some of their trauma or their anxiety if they're with the wrong person. So that can be a barrier, or possibly a plus in terms of Zoom or digital telehealth environments. Gauging that from a patient individual standpoint will be very critical before you just say, well, I only do Zoom, or I will only do it this way. You would need that flexibility. And of course, if an individual has heightened acuity, let's say they start expressing thoughts of suicide, or start having thoughts of wanting to hurt themselves, as we might hear in the case report coming up, do you just stick with Zoom, or do you find a way to touch spaces with them a little bit closer? That is what is next in telehealth, to say, when do you step it up to a higher level? Because if you're just in one space, you might miss something, especially if they have a tremor or a movement disorder that you might not be able to see over the camera. Knowing when there is a way to move things to a higher level and step it up, that's what we need to work out even more. So again, it's great for access, but more things to come. Now, finally, just thinking this through, it comes back to engagement as well. There are things that we call attachment styles, and I know Didi and others will think this through more deeply than me, but there are things that are called attachment styles, and ultimately it does become a way of how does that individual you're working with want to attach themselves to someone who's going to walk themselves across this bridge. Do they want them to be side by side the whole time? Or are they okay with a little bit of distance and reproaching every once in a while to check in, maybe every other week via telehealth? Having that conversation up front is really important as we shift into this world of using telehealth more and more. I see a lot of therapists actually not coming in, working in clinics like mine because they can hang their own shingle and have their own practice at home and do things by telehealth, but doesn't meet all of the needs of the individuals that we're trying to work with. That's the question that is to come, because we can do this in many ways. I can do this, in Texas if I wanted to, and do it at my computer. But will it give the need or give the thing that the client needs when you walk in the door or open up the Zoom window? It's not clear yet. And more of that work needs to be shown whether this way is more effective than in person, or do we set up a way to do both? So more questions to come with this mode of telehealth, but it is here to stay. Legislature is coming up in December to extend this another 2 years to examine it even more. And places like the Federal Communications Commissions are setting up ways to increase broadband access to do this in many more ways in many more areas. So I think it's something we'll have to ask a lot of questions about, but make sure it's safe for us and meaningful for whoever needs the help. So I'll stop there, but I do appreciate the time and looking forward to questions that come up.
Thank you, Dr. Antoine. I think we're going to open the floor for questions and comments from the group. I personally found it very interesting when you said that some people with PTSD would rather use telehealth than meeting someone personally. That's interesting.
Yeah, it's surprising. I have a group of individuals who have been through probably 80% of the folks I work with now have history of sexual trafficking. So being one-on-one in a space with an individual, and I'll say it out loud, a male individual, can be very heightening. And so I am cautious to make sure that first interaction is in a place where they're comfortable. Otherwise, it might bring back flashbacks of something that would be difficult to re-experience. And having that conversation, and going back to a previous session, broaching how to have that conversation and where they would like to have that conversation is very important. So telehealth can be a tool. I see now I see hands.
Oh, yes. Carrie.
Yes, I got a question in regards to how are you dealing with the difficulties with the literacy of some of the programs that are out there? We use the Teams app, and I find that a lot of times people have difficulties just kind of joining and getting used to that system. Do you have any suggestions in that area?
Yeah, so what we did, and it was literally me doing this because our IT department was closed. I think it may not apply to every space, but in our housing facility right now, I'm looking at a computer where I put an icon on there. And that icon is a direct link to my Zoom room, which takes out all the teams and all that stuff. They just sit down, double click, and that's it. So and on my end, I make sure my Zoom settings are video is always on, and I can bring them in from the waiting room. So taking away the steps that they have to do is possible, but I know it's always going to be this computer. If it's their own device, there are going to be some complexities there. We have applied for a digital wellness grant for the city of Baltimore that would help us get navigators for that as well, specifically to walk people through that space. But an icon, 2 clicks, making it easy, that's the best way to go.
Thank you. Janice?
I am very grateful for telehealth for people in rural areas, as Texas has people in very remote areas and they wouldn't get any help without this. But I'm curious, have you thought how you would measure the differences between someone receiving telehealth and someone receiving in-person that care?
Yeah, so yes, in terms of what's the outcome measure, I think the outcome measure could be a couple of things. One, the perceived helpfulness of treatment. And there has been randomized, it came out a couple months ago, and I didn't have a chance to insert it here, that showed that it has not made a difference in terms of the perceived helpfulness of that. Yeah, I think from there, it is that age-old question of what is the best outcome measure to know whether treatment is effective. Is it decrease substance use? Is it abstinence? Is it, just attendance rates? If you use attendance rates, then I think it wins. But I don't think that's the
Yes.
right one. But in terms of perceived helpfulness, the recent studies show it has not made a huge difference there.
Thank you. Lindsay.
Yeah. And this isn't quite what you were talking about, but have you had any experiences with I struggled with how to train my when I was a supervisor, how to train my, the rest of people in the organization, how to supervise somebody while we're doing everything online, right? So how do I, were people I'm trying to train them, how do I, normally you could sit in a session, but you can't really do that online? Like, how does that work?
It works with, and I'm laughing because I had a conversation about this yesterday with AI. It's a weird thing, and I don't think we're there yet ethically. But imagine a world, and this is what people are doing now. There's a company out there, and given that this is CME, I won't name the name, but there's a company out there where you can get recordings of these. We used to use tape recorders, and you sit down with your supervisor, listen over the recording, and say, here's some feedback. So that's one thing to do. You could have people record those sessions and then play them back. And I think that's one way to do it. The other thing that's starting to happen is that those recordings get lumped into a database, and AI analyzes them for fidelity to whether it's motivational interviewing or other types of therapy. That is what's coming. There are companies that do that now. But I think the suggestion in the present would be record just like you would on a tape recorder, and then play it back with the supervisor.
Thank you.
Thank you. I think maybe in the interest of time, we're going to be moving to announcements, but we definitely can come back to the didactics as we discuss the case presentation as well. So, Taylor, if we could please see the announcements. Thank you. The Center for Substance Use Training and Telementoring CSTAT offers technical assistance. Please remember this is a free service that we offer to all of you in the community. So if you're interested, what you have to do is go to our website, cstat.utesca.edu, and complete the form that it's there. We'll be happy to help. Next. If you are requesting CEUs for today's class, there is a post-session link. We're sharing it with you on the chat. And also, after this session, we'll be including that link in our email. So when you answer the survey, just make sure that you answer yes to the question, are you applying for CEU credits today? After that, you should be receiving your certificates in approximately 3 weeks. Next. And Be Well Texas continues with this very interesting research. If you know of someone who wants to participate, there is compensation provided for being part of this research. And the goal of this study is to give access to persons who use opioids to 24 hours, 24/7. All the time, permanently, access to behavioral health strategies, and the ability for them to better manage their use. Of course, assuming the person is also taking medications for opioid use disorders. So again, if you know someone who might be interested, just send an email here at bewelltexas@utesca.edu. Next. We're always looking for case presenters. It's part of our model. We believe that learning happens with real cases in real time. So if you or someone in your organization wants to present a case for us, just send us an email at cstat@utesca.edu. Next. Important reminder, next month we will not have a behavioral health session because of the Thanksgiving celebration, but in December, on December 20th, we'll have our session. So we're canceling next month's session and we are rescheduling the December session. You will be receiving a couple of emails giving you notifications about these changes and providing you with the unique link that will allow you to enter the December session. So just keep this in mind. Be on the lookout for that communication as well. Thank you. And I think we're going to start with our case discussion. And I would like to start introducing Bia, because I know we have two case presenters and I only introduced Melissa. So Bia, Melissa, whenever you're ready, we're going to start sharing your case form. And if you could briefly walk us through this case. Thanks. Bia, you may introduce yourself right
Thank you.
now.
Yes. Thank you so much.
Thanks.
I'm B Blackman.
Sorry, B.
It's okay. Some people call me Bay, so I get it. I'm a licensed master social worker, and I'm right now in supervision from an LCSW. I'm a program manager for Rise Inspire Academy, which is San Antonio's recovery high school. And in the high school, we work with adolescents, grades 9 through 12. Usually average age is 14 to 18. And Melissa, she will introduce herself, but we work together with our students. So would you like for me to begin, Melissa, or would you?
No, I can take it from here, B. Thanks.
All right. You're welcome.
Yes, Melissa Simpson. I am supervised by Jenny Harris. And today I have a case. The client is a 16-year-old freshman at our high school. When asked about pronouns, she stated non-binary until they figure it out. Prefers she, they pronouns. They identify as queer with a pagan belief system. The client's parents are divorced. They moved in with their father and stepmother in 2022. They explained that their mother introduced them to drugs and alcohol and would essentially buy them anything they wanted. The client presents with a history of self-harm, cutting, burning, several suicide attempts, suicidal ideation, no current plan, but states that they feel indifferent about life. She's been struggling with these symptoms since age 11. She reported that she began smoking weed at age 11 and became addicted to cocaine and meth, their drug of choice, by age 12. They've also used Xanax, cocaine, ecstasy, mushrooms, and acid. They also use hand sanitizer, perfume, and cleaning supplies. Clients shared that they were sexually assaulted and, quote, couldn't count on their biological mother or uncle to keep them safe. This client has been in 5 different psychiatric stays. Once they were where they were once assaulted. They've reported that they previously have been diagnosed with manic depressive disorder, bulimia, atypical anorexia, and social anxiety disorder. They're currently taking quetiapine, duloxetine, and hydroxyzine to manage symptoms. When asked about goals, they stated that they wanted to work on recovery because using wasn't fun anymore. They expressed wanting to be more body positive. We've reframed it as striving for body neutrality. Over the summer, the client expressed a willingness to get assessed by an eating disorder treatment center, despite feeling like they didn't deserve it because they're in a larger body. We did work together and they were awarded a scholarship, but the process was very lengthy. And by the time the intake came around, they had lost the desire to seek treatment. At this time, the client was using purging behaviors at school. There was some self-harm at school, and also engaging in sexual acts in our night alternative peer group programming. Staff agreed that this PHP would be a requirement for her to continue being a student at the school. The client feels like her social life and her friends at school, and being at the recovery high school is all that she has going for her. So we were hoping that that would be a good incentive for her to seek the treatment. The client only attended for a week and, in her words, sabotaged the treatment. They ingested hand sanitizer and ultimately was discharged. They explained that everything was just happening too much, too fast. They were also very triggered by other clients there that were in smaller bodies. The treatment center recommended that she attended a residential center in Dallas, but the father declined. My client stated that she would 1,000% kill herself if she had to leave treatment, if she had to seek treatment outside of San Antonio. She advocated for her preferred inpatient psychiatric placement here, but they would not take her due to her eating disorder. We referred Dad to another psychiatric hospital in San Antonio, but he took her to the center where she was previously assaulted, where she is currently inpatient, and she will be discharged soon. They're willing to go to treatment, substance use treatment in San Antonio, but they have Medicaid, and that has been just such a barrier. So the client currently, well, prior to this stay, has been meeting with a recovery coach weekly. For one-on-one sessions. They've been attending all our alternative peer group in the evenings. They also utilize intercession contact with the recovery coach. After the self-harming incident, we did place them on a behavior contract, which was effective. There hasn't been any more self-harm at school. She is receptive to in-session interventions. DBT seems to be the most helpful. Something that has come up in our sessions is that the client feels very triggered by my body. I am in a smaller body, and so we've talked about, what can we do to work through that. Telehealth has been effective. We were able to do some telehealth over the summer where I've seen the most progress made. Unfortunately, the client isn't often in crisis on campus. And so most of our sessions are in person. I found that sitting beside her has been helpful, or, just not sitting directly in front of her. So when working on eating disorder behaviors, her substance use increases. When working on her substance use, there's an increase in the eating disorder behaviors. So my questions today are, how can we better manage clients with dual diagnosis and treatment plans? Also, what are some resources and coverage options available for Medicaid, and possibly some more effective interventions for this case? B, did you have anything you wanted to add?
No, not at this time. I mean, yeah, you pretty much hit everything on the head, Melissa, especially looking at, that when she's not using substances, her eating disorder increases, and when vice versa. So trying to manage that and finding a stable space for her is what we're needing.
Yeah, and I'll just add that's been the most difficult thing is, she was feeling hopeful about the treatment, the eating disorder treatment, but they discharged her for her substance use.
Right.
We can't have her at the school right now because of the active eating disorder, and it is, does cause harm to our other population. So it's like, whack-a-mole. Yeah.
Thank you. Quick question that I was discussing this with the hub before. When you talk about body neutrality, what does that mean exactly in this context?
Okay, so I think we've all heard of like body positivity, and that's a great goal to get to, but like body neutrality, meaning just being okay in our bodies. Just, we don't have to shoot for having this, feeling love and acceptance of our body. Like, let's just try to be just okay with the body that we're in right now.
Oh, I see. Thank you. Didi.
Thanks. And thanks for all that, Melissa and B. I have to say that I'm getting triggered from a couple of things. And so I can appreciate that you two are probably feeling some similar things around this, and the frustration of here she's willing to do things and crying for help. That's what drinking sanitizer is, right? And you discharge her, not you, but she gets discharged from the very place she needs to be. That is, she is stated as her support system, and that's important to her. And it just, ugh, I get so frustrated because this is so typical. Even though we're supposed to be in 2024, nearly 2025, where we talk about behavioral health, not substance use and mental health. But here we are in the reality of that. I appreciate too that there can be concern for other students that are around. I think that the best thing that we can ever do is to advocate for our client to be in wherever they feel safest, and then help other people understand we can't make a place safe for everyone. That is not possible. That's actually your job, meaning the students. How do you help yourself? How do you learn to speak up? How do you create and learn what your own triggers are and cues are, and what I need in order to be safe? There's this false impression that we give around trauma that we experts are supposed to are supposed to create these safe rooms. And it's just not possible because everyone has different needs, right? So it doesn't matter if I'm in the classroom or if I'm sitting with an individual client, I can't do that for someone else. So I wonder if that's an opportunity where I'm getting to have those kind of deeper conversations with other students of what would it be like if she did come back? How can we help support all of you in this real life event? Because this is what happens. And, I'm feeling a lot for her because she's got a little bit of my story here to self-disclose for a moment, that she must be feeling awfully alone. The second piece of that is how in the world did she wind up back in the facility where she was assaulted? I don't understand that. And did I hear that correctly?
Yes,
Yes,
Melissa.
you did. We shared,
Yeah, I'm sure you.
yeah, the
Not
father was
blaming you.
aware. The father was aware, and
Yeah.
Did he not believe her? Do you think? I mean, yeah.
I don't know really on how to answer that.
Okay.
We
Yeah.
actually referred to another place here in San Antonio for her to be at, but the father and the mom wind up taking her there.
Wow.
Yeah.
Yeah. I mean, thank God the two of you are there. And it sounds like she has a connection with you, even if it's not always positive, if you will, if there's some tension there, and that's not always a bad thing, right? That's helping her to get in touch with things and to, it
Right.
sounds like, speak up for herself as well about what her needs are. And yet it's the two of you, and it sounds like the academy that she's really attached to. And so I'd encourage you to do everything you can
Bring her
to
back.
get her reattached. Yes.
Okay.
Say, what would it take? Let's try this.
Okay.
Yeah. Thanks. Sorry to be so lengthy.
Thank you.
Lindsay. Yes, thank
Didi,
you.
Thank you, Didi.
Sorry, go ahead, Lindsay.
Yeah, so I definitely have been in that situation before, I guess. Like where I spent a lot of my youth and adult life too being very cutting a lot and things like that. And for me it was really just it was because I didn't know any other way to get out what I was feeling that was good enough, right? So for me, and having that training and like of exactly what to do, like sometimes I would shove my face in, if I had to, like shove my face in water, in ice water, right, to get that immediate sensation to kind of stop myself from wanting to harm myself. Or if it wasn't as severe, drawing, I would trace my veins in a red pen to make it kind of look like blood, or a red like marker. So I'd show up to school with red marker all over me, but that's better than cut open wounds and things like that. And it was very like, so having those skills and having them, just remembering to do them and having them sent to me and taught over and over and over and over eventually helped me kind kind of get away from some of that self-harming behavior. Also, like I will say that having something that shocks your system was the most helpful for me, like the ice water, right? Because that like immediately snapped me out of whatever I was feeling at the moment. Um, and then also like I know that when I was in school, and I don't know how hard I was actually when I was put into a institution, I was removed from my parents' custody because they just wouldn't do anything about it, right? And unfortunately, that ended up saving my life, as hard as it was. And granted, I went back to my parents, but while I was in there, I got the skills I needed, right? And I got what I needed at the time to help myself through it. Oh, and I love you're focusing on just body neutrality. That's awesome. Because body positivity isn't gonna happen for all of us. Like it's just not. Oh, with that though, I did move from bulimia to trying to like exercise more, and that helped a lot. That physical activity really helped me with my weight and with my like energy and everything.
Good, good. Enrique.
Yes. I just wanted to share, I was going to echo Ms. Stout's comments because I have to say that I admire the two of you for doing what it is that you do because you're in such a difficult position. You have an individual who in essence, her growth was stunted when this use started, and the progression that all the rest of the individuals may follow through the natural progression of getting older and associating and correlating with other individuals and good positive reinforcing actions were lacking. And so we look for acceptance wherever it is that we can. The advocacy is the hardest piece to always teach to the consumers. I did direct care for 16 years and they will self-sabotage themselves until they get permission to say, you know what, I am worth this. I am worth that. And you two are fundamentally rebuilding this individual from the ground up to recognize the voice. It's not, in my opinion, it's not good enough for me to have a voice for an individual because I'm not always going to be there. I would rather you pick up the phone when it rings instead of calling me and saying, Mr. Flores, my phone is ringing. What should I do? I get mail. What should I do? You all are giving them the foundation and permission to be autonomous, to think about themselves, to look at the neutrality of what it is that's going on in their lives and not allow other perceptions to jade what it is that they're thinking. But this is such a strong barrier that it takes a lot of work. And when you're fighting on one side for the consumer that clearly wants what it is, but doesn't know how to get there, and a system who is so rigid in the way that they're thinking about what's in the best interest of the individual, these two things come to a clash. And unfortunately, you're in the middle. And the one that really loses out is the consumer because it's so. I used to tell clients, you know, the hardest part of recovery is that actual first step because we have to overcome all the crap that all of the other providers or all of the under individuals in our lives have put on us. And we have to overcome that and we have to see within ourselves. And when I'm 11 or 12, when I'm an adolescent, the most important people are my peers. And so this is where I learn everything from. And now you have individuals that actually you're a little bit of her peer because you understand a lot of the moving parts. They don't understand those moving parts. So I guess all of that to say, I feel bad that you're in such a difficult situation, but it's just beautiful that you rise to the top because the cream always comes to the top. And the best advocacy is showing them that they have permission to love themselves first. And then when they love themselves first, it's like I told, if you love yourself for even just a little minute or so, you can share that with somebody else because they don't want to talk to me. I don't have that lived experience. But with that lived experience, you can share with them, you know what, I've been down that path. And let me tell you how it worked out. And let me tell you what I used to try and get out of it. It doesn't work for everybody, but sparking an idea or giving them permission to have that idea is the critical portion of what it is that their recovery will be, I think. And I think you do that. I think you do that on a very regular basis. And you shouldn't feel that she's slipping through the cracks, because you're doing the best that you can and you're giving her all the tools that she needs. It's just growing into those tools, giving yourself permission to act on my own behalf instead of allowing other people to make those decisions for me. So my hat is off to both of you. I think you work so hard to get where you go. And I for one appreciate.
Thank you, Enrique. Katie, I think you were saying something before in the break room about her eating disorders.
Yeah, I was wondering a little bit about what the disordered eating looks like, because it's labeled as atypical. And it seems like that's been the primary focus.
Sure. So she would meet the criteria for anorexia, only she's in a larger body. So she does not meet the BMI requirements to be diagnosed with anorexia.
And what do you think is the relationship between the anorexia, the disordered eating, and her substance use?
Definitely used as a negative coping skill, a way to change the way she feels, a way for her to numb herself and also very self-harming, you know. I think it also ties into the self-harm piece. And I am also in recovery. I've been in recovery for 10 years now for substances and eating disorder. I went to treatment for several years, so I do share that lived experience. I think that has been very helpful for her. And I also think that I trigger her, so it's difficult.
Is any of the stimulant use also with the desire to suppress appetite and
Absolutely.
restriction? Yeah.
Absolutely.
Absolutely. But I mean, she has, I'm sorry, she has been, I guess like on a harm reduction. So as far as using any type of stimulants, I think it was just been like THC. So, and for us, we're like, yay. You're not doing that.
Right. In some ways that may increase appetite.
Yes.
And does she talk about that, or the relationship between the THC and the appetite?
Yes, she despises that after effect. But what she'll do is she's smoked before she comes to school, and then there's no food at school. There's lunch served, of course, and we have snacks available, but she also has a fear of she has discomfort around eating around people, so it's very easy for her to restrict while she's there all day, and then she goes home and purges. So it's just a cycle, the purge, binge, restrict cycle.
I think Lindsay's got her hand up.
And I know it's not popular, but I use stimulants as well to lose weight. And for me, the only way I was able to get off of them was to essentially go get onto medication for ADHD, right? Because that with a stimulant that stepped me down from methamphetamine, which is way worse, and I used that to kind of titrate myself. So the other thing is that for me, because I am very ADD and ADHD, right? That those stimulants were actually really helpful for me to be able to focus and get through college. There might be something like that coming into play, right? If we're thinking about like a harm reduction standpoint, being on stimulant medication may be better than being on substances that can be adulterated and can be tainted, and God only knows what's in them.
Thanks for bringing that up, Lindsay, because I was thinking of that previously, and Dennis had to step off, unfortunately, because I wanted to ask him to see if there was some medication that might be at least an in-between state to help her to be able to kind of be in her body or be okay with the discomfort, to the point so that we can move through that a bit and then get her into the DBT or whatever else she is finding helpful. And that might be the way to do it. And there is some evidence, growing evidence about using, safe supply, we might call it, so the pharmaceutical medication for people who are using methamphetamine.
And also, Lindsay mentioned something here that I think it could be also helpful. Has she expressed any interest in any activity like painting, drawing, anything that she just does because she enjoys doing it?
She's a natural artist. Like, yeah. So, and she does. She'll draw and I've seen her paint and sketch and write. I mean, she's highly intelligent young lady. She's an avid reader. So, and she has multiple different talents as far as like putting together like clothes, like actually like sewing, and like I said, drawing and art.
So maybe that's something that could be, you talked about having a party if she comes back to the school, or even just a gift in the meantime, if there's some way to give her an art package. I gave birth to an artist who's now an award-winning artist. And that's what I did with him. I learned to just give him the supplies and let him go. And that was the best therapy for him.
Yeah.
Yeah. See if you can tap into that. That's great.
Definitely will.
And so in my previous life, I did actually have an experience like that with several of the consumers that we had. We had a dorm attached, so we kind of had built-in clients, and we offered them an opportunity of expression for faces of what addiction looked like. And I mean, simple things, copy paper and colored pencils and things to that effect. And it had such a beautiful effect on the consumers that their expression of art, and it was unnamed and everything and put on the walls, and everybody was allowed to vote. But the expression, once they found out who it was, the sharing, the empowerment of being able to express oneself through art without critical views, and then the explanation. One woman did faces that were concentric going into a little bitty tiny one, and the larger one took up the whole face. And as it went up to a larger face, the colors changed from dark to bright colors. And then her expression on how each face was a phase and a change from her addiction to coming to reality is what she used to call it. And the top face was just so beautiful and expressive. She indicated that it was very powerful, and she really, really enjoyed it. I bring her up because she was the one that overwhelmingly won the little contest. And what we did was, like Miss Stout was saying, we got a little art package, and this is what you have. We're going to give you a gift card for Starbucks, and then here's this beautiful art package. Whatever you want to do, if it's okay with management, because I don't make those decisions. We don't have a problem putting it up. We'll put it up, and just can't have a name or anything like that. But you can share with people as they're walking down the hallway. Well, if you go down hallway X, you're going to see paintings on the wall, and one might be mine. So I thought it was a very powerful experience. I just wanted to share that since it was one of the things that came up. I thought it was wonderful.
Thank you for
Thank you,
sharing
Enrique.
that, Enrique. Those are all great tips. Anyone else? Any suggestions, ideas? How about her support network? Who are the people who are with her besides the two of you and the family? Anyone who supports her or who she can trust besides the two of you?
Her peers. I mean, that was one of the things, that why she wanted to stay as well in the school. She's got close to a couple of the young ladies here. So yeah.
Thank you.
Mm-hmm.
Dee Dee, I'm going to let you, I know it's not easy, especially in this case, but try to kind of summarize this case and give us a couple of hints or ideas of what
Sure.
you think that could work. Thank you.
So we started out with Dennis talking about what I always think is the most important part, and that's the engaging the client. How do we engage? And much like real estate is location, 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 for us, it's engagement, engagement, engagement. And how do we do that? And the reminder, too, of how important it is to listen to what the client wants to do, what they're willing to do, and make it available when they're willing to do it. And I'm not blaming anybody for that, just saying it's just a good reminder that we really need to work on systematically, not putting more barriers up for treatment of any kind. The impact of COVID, we talked about with the use of telehealth and how important that's been. We have learned a lot about the pros and the cons. We're going to continue to learn more about that, especially when it comes to infrastructure needs. One of the things we also discussed was the need for orientation around apps and platforms for our clients. And reducing those barriers to using those platforms as well. I have found that the use of text and email between sessions is really helpful. I text all of my clients the day before their appointments to remind them. I did that mostly for my own sanity as well, but it helped me to remember appointments and check my schedule, and they have found it extremely helpful. Looking at attachment style for individual, we talked a bit about that and understanding that when people are attached, like you two, she is attached to you and to her peers, then go in that direction, right? Play that up, work on that, and don't worry about what she's not attached to. I'd sneak in there, get her away from those parents, but I'll be kind here. Looking at art as a way of healing. Bessel van der Kolk talks an awful lot about this in his book, and looking at the importance of somatics, of moving our body in some way. That can be dance, it can be drama, it can be exercise. It doesn't make any difference in doing that. What I'm really hearing, I think, bottom line is how do we make lemonade from lemons, as my mother used to say, and finding ways to do that. And I think that's at the core of all we do, and telehealth has certainly been a part of that and will continue to be. So thanks, everybody.
Thank you,
Thank you,
everyone.
Judy.
This has been a good session. I want to thank again our two case presenters. They came up with a very interesting, engaging case. And thank you again to Dr. Antoine, and to all of you. Please remember to answer the post-session survey, and we'll see you in December the 20th. Thank you. See you later.